Okay, so we're welcome and pleased to have the medical director, Dr. Terry Vaughan, and Amy, when she gets here, Amy Fackrell, who is the CEO of Viewpoint Dual Recovery Center in Prescott. I thought it was really a good idea to showcase some of the other areas that aren't Maricopa focused, since we hear a lot about from the providers in Maricopa. So we're very happy to learn about the services for people in Northern Arizona or all of Arizona. I know you have clients from all over. So Dr. Terry Vaughan is a board certified psychiatrist and addiction medicine specialist with over 2 decades of clinical leadership, a graduate of India University School of Medicine and fellow of the American Psychiatric Association, where she served as medical director at West Yavapai Guidance Clinic, leading a team of 16 providers in a comprehensive psychiatric care program. She serves as the medical director of Viewpoint Dual Recovery. And she's been honored by NAMI as one of America's exemplary psychiatrists and is recognized for her clinical excellence and dedication to patient care. And then Amy Fackrell, I'm not sure if she's on yet.
I'm here.
Yay. Okay, Amy.
Yeah, I'm here. Yeah. Hi.
Yay. She's a visionary entrepreneur transforming the future of mental health care. After earning her law degree from Northwestern, she built a successful career in securities litigation before leaving private practice to confront America's mental health crisis. In 2010, she co-founded Viewpoint Dual Recovery Center in Prescott, growing it into a recognized leader for treating complex addictions and co-occurring disorders. Amy is also the CEO of Myogenes Inc., the American division of Myogenes.
Yeah.
And she leads breakthroughs in pharmacogenetics and personalized medicine, pioneering solutions for treatment-resistant conditions and reshaping outcomes for vulnerable populations. And with that, I'll turn it over to you guys. If people have questions, you'll see their little hands raised, or we'll monitor the chat. Do you prefer to wait to the end of all your slides for questions, or do you want questions as you go?
Terry, go ahead.
Go ahead, Amy.
Well, I'm fine either way. I was going to say it's really up to you how you want to do it.
Yeah, I think maybe it's not, the presentation isn't going to take too long, so probably we should wait till the end just so we can figure out how to connect everybody with the questions. It's usually a little easier to do it that way. So if somebody feels a burning desire, though, they can go ahead and ask. So that would be fine. So I'll go ahead and keep on. Oh, I'm going the wrong way here. So there we go. So this is just a summary of what we're going to talk about today. And, we're going to focus on, the Arizona mental health crisis, the current landscape and workforce challenges, talk about Northern Arizona and our SMI population. And I think most of the other people that are there are from the Phoenix metro area, I would think, but we'll at least let you know a little bit more about, as we like to say, rural psychiatry and mental health treatment, talk about cost saving potential of and financial benefits of residential treatment programs, which is one thing I think you all have been working towards, is trying to support the need for more treatment facilities in Arizona. And then we're also going to talk about the facilities overview in Northern Arizona, what we have to offer, and as well as looking at our program here at Viewpoint, which is a program that's specifically for patients that have chronic mental illness and dual diagnosis. So the next topic is about family barriers, and then we're looking at policy solutions, and then at the end, we'll talk about questions and collaborative dialogue. So Arizona's mental health, we have 10% of our mental health needs met when they're looking at statistics in Arizona. And that's from the latest data from actually the beginning of this year. As you all probably know, we're 47th in the nation for behavioral health workforce availability. We are 144 providers short in Arizona. This is psychiatrists and prescribers. And most of the providers are in the urban areas in Arizona. So, places like Prescott, Flagstaff, other, especially the Native American tribal areas, there are not psychiatrists or other mental health providers to meet that need. Then population size, there are 7,745 individuals in Arizona that are SMI, and 12% of the state's population is up here, that's SMI. So the median age is 51 years. The predominance is female, 55%, 45% male. Statistically, 58% are Caucasian, and then unknown for 28%. And then in Northern Arizona, there's a fair number of Native Americans. So 100 million expenditures in Northern Arizona, and statewide is $1.13 billion spent this last year. Sorry, that didn't mean it. 4.7% of our seriously mentally ill are incarcerated, 5.5% homeless, and actually I would be willing to bet it's higher than that. And about almost 15% are employed. We're talking about, the economic case for residential treatment. And of course, it reduces costly hospitalizations. There are fewer emergency room visits, fewer inpatient psychiatric stays through preventative residential care, helping with medication compliance and keeping patients, out of trouble. It decreases cost of homelessness, supportive housing, reduced overall costs by 12% while improving outcomes, and it avoids criminal justice expenses. You probably know, the crisis residential programs alone saved $2.8 million annually in Arizona, and the ACT teams are part of those savings as well. So in Northern Arizona, we have, the big players for treatment up here, Polara Health, which is the former West Yavapai Guidance Clinic, which is where I was medical director for many years. Then Spectrum Health, which has been over in Cottonwood and in Sedona, and that is another provider that provides services actually throughout the county here now in Yavapai County and also in Coconino County. And then Southwest Behavioral Health, which has been a big player down in the Phoenix area in Maricopa County. Then we have treatment at our community health center. There's a tribal REBA with the Yavapai Apache Nation, and then NAS Care, which is a peer support program that has wellness services up here. So bottom line, there's some policy priorities, and we're trying to break down barriers up here as well. We're trying to restore funding for some of the secure behavioral health residential facilities, and expand workforce development programs, continue residential support for stabilized patients at high risk for relapse, and address the there's waiting list for getting into these inpatient or for the residential treatment programs up here can be, actually, I've heard of patients waiting for over 5 years to get in. And I'm sure that you guys have the same problem down in Maricopa and down in Tucson. I know they have the problems as well. So family advocacy challenges. I think one of the issues that we see all the time is the anosognosia, where, many of our patients with schizophrenia or schizoaffective disorder lack awareness of their illness, and they don't, they deny that they have any problems. they are, not thinking that they need to take medications, or, some of our people, especially when they get manic, they think they like how they feel when they're not medicated. There's definitely HIPAA barriers for families when you have a young person who's in treatment, and a lot of providers have very conservative interpretations on and it limits family involvement. There are, a lot of debates about civil liberties versus protection of patients, and there are issues with balancing patient rights and with safety. As probably many people there know, there are issues with legal advocacy groups like ACLU and the DRAZ, who oppose involuntary treatment and then sometimes make it difficult for families that need to get people into treatment. We at myself, and I think Viewpoint in particular, we're trying to support families and to try to get treatment for their loved ones who need treatment when maybe they're in denial of their issues. So the next part is about Viewpoint, and I think I'll let Amy do that. If you're comfortable with that, Amy?
I'm never comfortable talking in public. No,
yes,
I think.
We know you are.
So first of all, I want to say hello to everybody, and I want to thank Acme for having us talk today. It's quite a group here, and I know a lot of the faces, or I've seen a lot of the faces, and we're really excited to be asked to be a part of this, and really want to support what you guys do. I mean, 31 bills into law, I think last year, or something incredible like that, and just all the work that you do. That being said, in 2010, and I want to thank Dr. Vaughan for being a part of this. I don't know if we'd have Viewpoint without her. We've kind of all come together and created this special sauce up there. And when Viewpoint first started in 2010, we started as addiction. But one of the things, and my mom is one of the co-founders, she always felt that, yes, drugs and alcohol, it's a terrible scourge, but really there's an underlying untreated mental health problem that's going on, and and that's a symptom, and so, but we didn't know, right? There's, did the drugs come first? Is there underlying mental health? So that's kind of how Viewpoint was born. And over the last 15 years, with incredible people like Dr. Vaughan, we've got Dr. Julia Summers, and then Joe Finger, who's lurking around back there, and we'll have to introduce soon. Yes.
He's hiding.
Oh no, he shouldn't hide. He's a big part of what we do. And so we've had a lot of good successes. Some of the people in this room we've met along the way, the journey, whether it was through just advocacy or trying to just being involved in this. And then there's this person who just put her little note up there, who we met in a different capacity. And I'm so grateful that we did, and so proud of the work that she has done, and just getting the word out for those families. I will tell you that one of the things that we required from the very beginning is that families needed to be a part of it. We felt it was always a family systems issue, and that it's not that the parents caused it or anything, but it's that, all of the things you know well about, that the families are, they're the caretakers. They're the ones who are taking care of their loved ones, and they have not a lot of support sometimes, and not a lot of resources sometimes, and certainly a lot of barriers. As we've been at Viewpoint, we've encountered those same barriers. We are a private. We do take private insurance, but we are very excited to announce that we are going to be going in, knock on wood, in network with Access, because we want to be really the first secured behavioral health residential facility in Yavapai County, maybe even in Arizona. And that is what we are in the process of trying. So if anybody wants to put in a good word, we would welcome the assistance. I can tell you that we have had tremendous success. We have never, ever treated a patient like they are their diagnosis or anything like that. Never accepted that, a a lot of times they hear, well, you're just going to have to, this is the new normal and all of that kind of stuff. And we've never been like that. We want to, everybody needs a reason to get up in the morning and a purpose. And we'll do our damnedest to help you try and find that. Dr. Vaughan is so key because she's in the beginning, we have a lot of people who, I mean, thinking about the future is so far beyond where they're at. And we've been lucky enough to be able to keep people for a very long time. Of course, insurance companies are fighting that more and more, and we're having, everybody's having difficulties with trying to pretty much, well, thank you, Karen. We are very much fighting with insurance companies to get even a reasonable reimbursement rate. In fact, we just had an insurance policy, and this nicest family, and for this happened to be for a PHP level of care. And we bill at the usual and customary rates, and the insurance company thought that we should get $177.54, and that includes Dr. Vaughan's time and everything she does. And that is just untenable. So, and then putting this all on the families. So what I have been trying to do, and we have been trying to do, and I know you have been trying to do, is, if the government isn't going to help us fix the broken system, then it's up to us to do so. And that's how I've met a lot of you incredible people along the way. Viewpoint, we take the patients, and I can't tell you how many calls I've gotten from the facilities that say we treat mental health, and they do. Besides, by the way, everybody's depressed and anxious when they come off drugs and alcohol. But then when the drugs and alcohol wear off and there really is the mental illness, I've gotten so many calls, please help. And that's where we come in. And Dr. Vaughan, probably, she and I have a lot of stories along the way, but the people that we've helped is what makes us keep going, because it's tough. And so, Lori, you're one of my, your family's one of my most special stories, by the way. And that's what keeps us going, and just if we can help anybody. But I feel like we can help on a wider scale. So that's why supporting what you guys do and being a part of that is amazing. And then, you know what, I'm going to talk and then I'm going to answer the questions, because I have a little ADD, I think, today, and I don't want to get thrown off, and I want to just say what I have to say and not bore you with too much and allow the questions to come. The other thing that's important is that this is a global problem. This is more than just a local. I mean, we have to start where we have to start, but there's only so much that we can do. We are keeping people as long as we can. We are doing the best we can in creating networks for aftercare. That's where there is definitely a big hole in the system. And it's very complicated. And I know a lot of people have tried, better people than me have tried, and there's just, it's hard to get it covered from a business standpoint. And so what I also did was I was lucky enough to be introduced to some people. One is a Dr. David Taylor, who's probably, no offense, Terry, because you are amazing. Because we've been using clozapine at Viewpoint. I don't know. I think since the beginning of time, I don't think it was something that we wouldn't do. It's, of course, clozapine is not, the first go-to, the first line of defense. It's sometimes too bad that it's not, but I understand, with the side effects and everything and all of that. But we had clients on clozapine. We had one girl, we ended up having her for about 3 years. And she came in, she thought she had a chip in her head and her boyfriend was controlling her and all of that. But 3 years later, she ended up leaving us, and she had an esthetician degree. I mean, we will go that extra mile. And Dr. Vaughan is the most, and I say this with all due respect, the most normal psychiatrist I've ever met. And I personally have met many, and has an ability to connect with the patients and help them understand in a way that I really have never seen. And that's, and I'm not, and Rachel agrees.
Wow,
And
thank you, guys.
and I mean that, because it's not easy. And we do have, it's complicated work. But it's just I feel like she's been able to talk to some of the patients and help them. I mean, they don't know what's going on a lot of the time. Yes, there's anesthesia, there's all of that going on, but it's important for them to have some power and control in this and feel like they are a part of the decision, because they probably felt they're not for so long. So in that aspect, that's what we've been doing. And then I have to tell you, Dr. Vaughan has been on the fly a lot. There are a lot of late nights sometimes, but that's what you do. That's what you do to help these people. So I don't want to, belabor it, but I will tell you, I'm very excited for Viewpoint in the sense that we want to become and be that shining star to show that the secured behavioral health residential facilities can be done and can be done correctly. I've talked to so many people. I get calls. I went to the group home where my loved one was staying, and it was filthy and it was disgusting, and that's not okay. That's not okay. So with Myogenes, as I alluded to before, what we are doing at Myogenes, and I have really incredible people with me on that journey, is there's been a test that's been created, because one of the things about clozapine that was so difficult was the REM system, which it is now out of. But there's also nothing that was set in place to replace the REM system and kind of educational REMs. So this test that was created, one of the things that has kept people from having, and certainly a lot of African American or people from African descent have been unable to have clozapine, is because all of the blood levels and somebody else could speak to this better than I can, but they're based on white Northern European males, not even females. So that kept a lot of people from getting access to what could probably have been quite a game changer and a life changer. So working very hard in that precision medication. We're not 23andMe. And so one thing at a time. And then the exciting thing is that it will give a starting dose and a target dose, 4 different things, depending on these genetic markers. And it tests 10 gene alleles. And that's just the beginning. We also have a patent on and are working on some incredibly, what I feel are game changers. And I think that the other people involved think so too. A subdermal medication delivery system that will, that can be for a long term. And it can be used initially for an initiation. And it can also be used hopefully once some of that insight maybe comes back a little bit, or they're feeling better. There's a lot of statistics that show once people have been on clozapine for a while, they actually continue to stay on it. In our experience, Terry, I think we've had both, really. We've had some and some, and I think that depends on their support system. And then lastly, there is a nasal spray that we are very excited about in development, that we believe, or we know, that the intent is for it to drastically reduce the milligrams that are required on a daily basis of clozapine, which is what causes all those negative side effects, and goes directly into the blood-brain barrier. And hopefully that is, I believe, one of the biggest drawbacks are the side effects. And again, what Dr. Vaughan did from the very beginning and is to aggressively treat side effects. We don't allow people to sit at home and just sit and have, terrible blockages and be, severely overweight. We do whatever we can to get them moving. So that's Viewpoint, but mostly it's about Dr. Vaughan. But in terms of Northern Arizona, we really are it. We have actually been really it, especially with clozapine titration in certainly the western part of the country for a very long time. There are others doing it. There are some people on the East Coast doing it, but doing it correctly. And so that they have positive experiences with that. Our biggest problem has always been, and then this is not like, I'm not saying anything bad or good, but the public system in Yavapai County has been complicated to work with. Everybody has a shortage of good workers. Everybody is overworked. There's shortages and all of that, and not enough manpower to go around. And so many people who that we don't even know that are running around who could really benefit from the services. And so when we have somebody and we have to title them, where they go and they don't go to, like CBI, they go to the Polera Crisis Center where they're evaluated. And if it's determined that they need to be on COT, then they are transferred to a new facility was just built. It's over by, Terry, it's over by,
It's by the jail, right? You're talking about the one by the jail.
yeah, it's called Connections. And that one I've not been in because I don't think we're really allowed in there, but it's kind of a similar, like a Valley-wise situation where they're there and then they can have the court hearing and everything while they're in the facility. And then after that, well, that's where there's that big hole. And hopefully they can come to us, if that works out. Otherwise, is a very small, how many beds do they have at the, I don't want to call it the happy place, the healing place, sorry, the healing place, sorry. Where they have 32 beds or 24 beds is
I
all?
think it's 24 beds.
Okay,
Yeah.
24 beds for the acute, and the length of stay there is very short. And then there is no place for them to go, as Terry was talking about, or Dr. Vaughan was talking about earlier. So a lot of times and that's all we have. So we don't have the luxury. The Yavapai Regional Medical Centers, they do what all the ERs have to do, and they'll get a client and then they'll try and find a placement, or there isn't one, and then there's being sent down to Phoenix if there's a bed, and sometimes there isn't, but that's not always ideal when their support group, going to Phoenix, if your support is in Yavapai or up in northern Arizona, that's when a lot of bad things can happen too. And so, yeah, I mean, I'm sure I have a lot more I could talk about. I certainly want to open it up for questions. And I want to again, thank you guys for allowing us to speak today in front of you.
Thank you, guys. So the first question I see in the chat was, do you accept clients from Maricopa County Access Pay?
So we will, yes. We will be taking Mercy Care or Arizona Complete.
Okay.
And I think that would be, Lori, I'm going to let you take these questions because I want to answer, and I want you to, if that's okay. So,
okay.
Yes,
So
we
the
will.
next one?
Yes. Yeah.
Okay. Are you funded through the REBA, and where will funding come from for the first secure facility in Northern Arizona?
Well, we're working on that, but yes, that is what we're hoping to see happen. Now, remember, we are going to have we can have some private beds. We do want to keep those beds open for that, but that's what we're working on. And it would be through that, yes.
Okay. And then Rachel had a question just confirming development of both intranasal and implantable or subdermal.
Yes, subdermal
system.
medication delivery system. Yeah. I'm
Is
sorry.
underway.
Yes, they both are. Yes. In fact, very close to completion.
Okay. The next one, they're talking about their son graduated from Viewpoint Stellar Care from Dr. Vaughan and Dr. Summers, is living independently and volunteering in town. Where in Prescott could they go for a job training or supportive work environment?
Okay, so excellent, because I actually we just were going through that. We have NASCARE up there. The way that we've done it with the people who graduated from us is that we really are a step down. So we have clients, and it's very individualized. And we try to do whatever we can. If it's healthy for the client to not go back to where they were, and they can stay in Prescott, and they already, before they graduate, or have volunteered or are working or going to school. We also are big proponents about going back to school. In fact, we have a young woman right now who's so proud of herself. She's back in school, and that has been a long road, and we're very proud of her too. Although she's getting to be, interestingly enough, just like a college student, calling in and asking for money for stuff, and it's cute. It's wonderful, actually. And so the problem is housing, and there is a shortage of that. So, but what we do is we get them started going already, and then if they have a job, we will ease them in. They can stay with us where they're not like doing the services, but they're living with us, doing medication management, and then they're working. And we kind of have been creating these hybrid programs along the way to accommodate the client and their families, because everybody's got so much invested. And then we have one young lady right now who actually is in her own apartment. Now, there are some issues apparently with whether or not she picks her socks up, but it's not my problem anymore, right? And so if that's the worst thing, but she's loving school and she's doing great. And the good news is that they can stay with us in terms of we can have some oversight and connection still, and they have a community that they've created.
Okay, and the next one is, I think Dr. Schwartz is asking, do you mention whether Myogenes is thinking of a long-acting injectable for clozapine?
That's the
So
dermal. That's the subcutaneous one is the long-acting injectable.
long-acting injectable, yes, I guess you would call that
That's
an
what it is.
injection. Yeah.
It is. It's the same kind of medication. It would just be a long-acting kind of like we're using for the Suboxone, you know, the
Mhm.
Subtext kind of long-acting too. So
Mhm. They
Another,
actually in the UK they have a daily injection, but that's not something where you have. It's not good. I mean, it's difficult. Even they don't like to use it because you have to hold them down and stuff. It's
oh,
awful.
geez, no.
Yeah.
Rachel wants to know, do you have any ACT teams up north? I know that they've had some issues in the past.
I don't think there is one right now. There was.
No. Yeah.
I know when I was med director, we had it, but I don't think there are anymore. That
Well, there, can I interrupt?
go-
This
yeah.
is
Yes.
Dean Wellens. There are ACT teams at Polera, if that's what you're referring
Um,
to.
Are there? Okay, thank you.
Yes.
I did not realize
Very,
that.
very, very good ones too.
Okay, good. Thank you. So
Yeah. No, I mean, there's a lot that's gone on because there's been a change. It used to be West Javapai Guidance Clinic.
yeah.
And so I would actually love to sit down and meet with you guys and see how we can work together. One of the things that's happened is like a lot of people have gone back down to, some of our clients come up to us and then they go back down to like the Valley, and or they are court ordered treatment and they have a Reba down there, and then don't we transfer them up, I think, to Polera, if I'm
We-
not correct, right?
Sometimes we do if they're going to stay here, but usually they go back to where they're from. I mean, we've had a few people that have gone to Pollara because their families are up here too, though.
No. I mean, once they've been court ordered, and once they're on
Oh.
COT, yes, then they can transfer from Maricopa up to Yavapai. We have done that. And then some, in the past, we've had to just do reports. They've kept them there. And then other times, they are transferred completely up to Yavapai. But that's more probation, I think it is, than the COTs.
Usually
Okay.
we'll just take over the COT while they're with us and let them know what we're doing. So
Mhm.
yeah.
So Janine Simpkins has a question. What does the application process look like to get admitted to Viewpoint? And do they come directly from a hospital discharge? Can it be admissible part of a COT plan?
So, Terry, you can speak. Yes, they do. They come straight from the hospital. They
And Joe.
actually, I want
better.
Joe, actually. Joe,
Yeah,
put
Joe's
yourself
the
on
one
there.
who knows better. So
Hello.
yeah.
I mean,
This-
a lot of.
Wait, introduce yourself. This is Joe
I'm
Finger.
Joe Finger.
Yeah.
Meet everyone.
Mhm.
Medical coordinator at Viewpoint. A lot of the time, yes, patients will come straight from the hospital. Sometimes they come from home. The application process, it's not strenuous. Basically, as long as there's no like extreme risk factors, and you want to come, you're welcome, you know. So
Well, it's a little bit more than that. Yeah.
You have to
It's-
pass a
it's a-
pre-screen and certain things,
And
So
but
be
you're not doing
appropriate,
pre-screens
yeah.
for a while, Joe. No, I'm just kidding.
yeah. So, yeah, you can come right from a hospital. You don't have to. We prefer people to be stable when they arrive. They don't have to be, as long as they're not, you know,
Actively suicidal or.
yeah.
Yeah.
So, that's the gist of it.
And we've gotten a lot of clients that they said, oh, they're just fine. The records say they're just fine.
Yeah.
And then we've had to put our arms around them for a while.
And the opposite too, though. Sometimes the records say they're, you know, not, and it's a pleasant surprise, and they do
Yeah.
very well.
Yeah.
So,
Well, there are the ones that, and one of the things about Viewpoint that I'm proud of is that a lot of times when somebody is in psychosis, they can get quite violent. I mean, we had one kid, must have been a buck 35 soaking wet, and he took out 2 huge police officers, you know, because he was scared, he was psychotic, and that doesn't keep somebody from getting in. But we do have a process where we do need to get the records and make sure they're appropriate because we want them to be successful. And so if we don't feel that they're appropriate, then we will help find, the one thing we do is we help find where an appropriate place is, and then they can come to us. I think that's fair to say, guys.
that is fair
Yeah.
to say.
Mhm.
If you need stabilization somewhere else first, then we generally
Yeah.
help with that process, and then hopefully
Mhm.
arrange a viewpoint.
And I would like to add, just, you know, kind of looking at the type of person that comes to us, frequently we'll see someone who's on medications, but maybe not doing well on them. And so then my job is usually to kind of work with the patient and then talk with the family about, you know, what they've been on before, how they've looked on different medications. And then, you know, we frequently use clozapine because a lot of these people will have been on other meds that haven't worked for them. But whatever is the appropriate medication
Right.
to put them on is where we go with it.
Right.
So, but we'll start meds, you know, if people come in, and we've had a few lately come in with no meds at all, and very.
No, they had
psychotic.
meds, they just weren't taking them, I think is what the thing was. Yeah.
I don't know. We had one guy that wasn't on anything recently. Amy, you may have missed that chapter. He was cooperative, but he wasn't on anything and was very psychotic. But we were able to deal with that because he was at least wanting treatment. So yeah.
And I think
And-
that's another important thing about Viewpoint and about what we do, and is so important, is that it's a non-judgmental
Yeah.
place where, and we're very supportive, and we do not allow people to, you know, be bullying and things like that. I mean, we can't help what they do on the playground sometimes, but honestly, that is not the culture. Is to just be very kind and loving and try to create safety, right? Isn't that what it's about? Creating safety. And maybe Dr. Vaughan, that's why they like you so much, because you make them feel safe. So
Very good. I
Okay.
can see there's more questions too, right, Lori?
Yeah, how many clients live at Viewpoint, or how many clients in general, and how many live at Viewpoint?
So there's 23 actually. And I thought it was 24, but we are about to add an additional 10. So we will have 34.
And our
And
census
then,
varies from time to time, you know, goes lower and higher. So,
Usually it's right when school starts or after holidays. We get a lot of calls. And I mean that, I'm not laughing at it. There are definitely times of year. And then, you know, but we also, and we also make sure that, and one of the things is the therapists, the first week that the client is there, they make contact with the families, and they set up a weekly session with the families, not to be their therapist, but to keep the families involved. Because one of the things we've always heard is that they won't talk to me, or I don't know what's going on. And, you know, and that, I don't understand that. So, and again, we've got people who are burnt out, or they need to help in accepting what's going on. And for the sake of the patient, for when they leave, you know, we want it to be a healthy environment. And so we try to do that with the families, and then they will have visitations and go out and do things. And we've had to create a list of what you shouldn't do, like go ATV riding and things like that. But I'm sorry.
I think that was just background.
Oh, I'm sorry. Okay.
Yeah.
Yeah. So,
Yeah.
And
and we
the
also,
next
we
question-
also like them to go home. I think at least if they're going to be going back home, we definitely, before they leave, like a month or so, try to do a family visit so that they can come back and process that with us also.
And the question, when do you think that Viewpoint will be an official access provider? I think it's in process.
It is in process. Oh, no, the application's in process. It's about the secured birth,
Okay.
is what we're talking about. And that is a question I can pose to some of you there. So, it's a work in progress and hopefully as soon as we can.
Mhm.
And is Viewpoint ever going to have residential level care? I think they do, right?
Well, we
No.
do, and so that will be resident, that is residential. Yes, we will have residential care. The way that we had initially set it up, and I don't want to use the dirty words, but it was the way that a lot of places, when we started in Prescott, I can't even begin to tell you how many facilities there were. And then after that, I mean, it was like, they called it the proliferation of like sober livings and things. So we have lovely houses in neighborhoods that are staffed 24/7, but that they live there. And because of that also, we've been able to, it's kind of mimics a more normal home environment. And they learn, well, we don't necessarily do the therapy there. We do set it up to be a secured, safe environment, and we teach them how to do their laundry. I mean, we have, we teach them how to cook and do some things. You can only lead them to water. They still do like their burritos and things like that, but we try really hard to change that. The residential is going to have somebody, of course, they get provided insurance.
Mhm.
And it said you work on parallel SMI and addiction.
Why, yes, we do. I don't know the percentage. Dr. Vaughan might be able to speak to it better than I am, but there's typically drugs and alcohol or some kind of addiction involved in, what would you say, 95% of the patients that we get. Sometimes that's what brings them to us.
Yeah, I
Um,
think it's probably more like
Is
85%.
it? Okay.
Yeah, it's probably a little lower. I mean, we do get people where it's just pure SMI and they're not having addiction issues, or people with very mild addiction issues, or it's been in the distant past, that kind of thing. And we don't typically, so we work with dual diagnosis, and typically we're not dealing, in our program with people that are only having
Yeah, no.
addiction issues. It just, they don't fit with what we treat. It's just not appropriate. So, yeah.
And then
But we do
again,
train them. Oh, go ahead. Go ahead.
it was just, is it a secure facility currently?
No. No, it is not.
Okay. And do you do electroconvulsive therapy?
Mm-mm.
No, we do not.
No, no. We usually have to refer down to Phoenix or up to Flagstaff for ECT. So,
Okay. I think Rachel wanted you to talk more about your addiction treatment work.
Okay. Well, Rachel, you can come off mute. You've been intricately involved in that.
Yeah.
What questions are you asking?
Well, there had just been some questions in the chat about whether or not there was addiction treatment and so forth.
Oh, yeah.
And so we had been talking mostly about SMI in
Yeah.
mental health because this is, an ACME setting, but having family members graduate from Viewpoint, there's and many of us that are joining today, our loved ones are still sober, still participating in 12-step programs. My recollection was that there were several 12-step meetings that the clients would attend, and they made that a part of their routine, including
Gotcha.
on weekends. That became community. There was 12-step work requirement. And, if someone wasn't super ready for 12-step programs, you guys are pretty flexible on some things. So
Mhm.
that was,
Thanks. Yeah, thank you. So yes, actually, they go to daily meetings. And again, and that is a requirement. And that's a lot about, you can always get something out of a meeting, don't you think? And meet people and be social and find people like you. And it's interesting. They say they've never had a drug and alcohol problem. And sometimes after going to a few meetings, they kind of rethink that. But it is about community. And there are a lot of meetings still that go on all the time. Not as many probably as there used to, probably when your loved one was there. But and we do try, we have had people who are not in addiction. I'm sorry.
Joe and I say there's a lot of meetings. There are.
Okay. Well, I will believe you because I'm not up there but those, but
there are.
I want to have Joe sign a card. So I want to know what he really knows. But anyway, but that being said, yes, that's a big part. And because so many of them, I mean, if you're talking 80%, 85% have either abused or full-blown addiction. And because that's not a good combination with other things that are going on, like the mental health, we want to, we have that conversation. The groups talk about, and it's about, spirituality, have belonging to something bigger than yourself. We do not throw religion down people's throat, of course. And we have a lot of copies of, I think, the Jewish 12 steps. We have the Buddhist one. And there is actually, is there still that Buddhist temple up there, Joe?
There it is. Yeah.
I think that there's a Dharma.
There's a Dharma meeting for recovery. Yeah.
Right. Whatever's going to get them involved, you know what I mean? And whatever and the really cool thing is that they can feel accepted, and when a lot of them have felt so isolated in the past. And yes, it is a requirement, and even when they don't like it.
I have to throw in a couple of quick things. So Prescott is a widely known recovery town. So there's a number of substance use disorder treatment centers. There's a lot of 12-step meetings all around town, different flavors of 12-step, AA, CA, CMA. I believe there's even like a nicotine anonymous, apparently. So the one thing that I've heard is something they call it the Prescott dream, where you get to go to work for the treatment center you graduated from.
Oh God.
So that's what they call the Prescott dream. And there's, you probably have hired at some point folks who graduated from your program. And I personally like Prescott for a lot of those reasons. So I just had to throw that out there.
No, I appreciate that. Actually, Joe, and I think it used to be like that. It was actually a rite of passage if you were able to be a house manager after, because you weren't in treatment anymore. And I think it was really cute. We actually do not hire our own graduates to do work, but because that's just, they need to be separated from us for a little while and go out and do stuff. But that doesn't mean that they're not welcome all the time. And
all the time. Yeah.
Yeah. I think that's because we did hire one a very, very long time ago, and you live and learn sometimes. But again, everybody's welcome, and we want to stay connected. The one thing that is really important is the med management piece, because I mean, Dr. Vaughan is managing their meds. We know that they're coming. Joe Finger can talk to them, or Aurora, other people in the med room can find out kind of on a daily basis what's going on. And I will tell you one thing, even with people who have done as well as even, Carson and some other people's children, I still think that people need more than one set of eyes on their medication, because I know I forget, sometimes whatever I have to take. And I think it's important, and it's so dangerous if they go down that slope and stop taking some of this stuff, and we can catch it faster.
One question, someone asked, have you ever thought about having a center like this in the Valley, like Viewpoint?
We did actually. We did for a while. It was right before COVID, and we closed February. It was at the end of January, like February 1st of 2020. And we did. We also liked Prescott because it's not Phoenix. They're not in their backyard. They are somewhere else. We also know where they're at all times. We work a lot with the first responders and the police, and I wish that the sheriff was here today. I would like to get to know him better, and I know he's heard of us, but I think they do such a good job, the Prescott Police, with working with this population, at least what our clients, because we're there, we wouldn't let them do anything else, but they also, they'll find our people. There's not a lot of places to go. So it's kind of safe. It's also not easy to walk down the mountain to Phoenix. And so we like it up there.
They go to Whiskey Row. That's where we look
Yeah.
for people.
Yeah.
Literally, my mom has walked into a bar before to get them out. That's the funniest. Yeah.
Yeah, we
Yep.
know where to go.
One question, it's interesting because your stats are 55% female and
Mhm.
45% male in Northern Arizona, which is so unusual. I mean, the stats typically are like, 70% male, 30% female, and the age is
Yep.
was higher also. So why do you attribute females and older in such
I
a disproportionate amount?
I think part of it is that our population
Yeah.
is the majority older, like our general population. We have fewer young people here, which might be why it's a little safer when people wander out, because there's not as much trouble to get into. You're hanging out with geriatric people. So that's part of it. But the other thing is that those SMI statistics are looking at all diagnoses. So there, you can be SMI and be borderline, you can be depressed, you can be anxious. So typically, that a lot of people with mental health issues are female. So, but I think if you were looking at only schizophrenia, you would probably be seeing more males. That would be my thought.
We
out.
have a much larger male population than we do
Yeah,
female.
our program is more male, so for
Mhm.
sure. But that's
Yeah.
just data. Yeah.
Okay. And then Rachel had a question about volunteers. Do clients still volunteer at the?
Absolutely.
Yeah.
Absolutely. The DAV, absolutely. And sometimes they get asked to not come back and sometimes, but no, they do. And the other thing is that we encourage them to find some hobbies and stuff. And I mean, that's one of the things, whether it's addiction treatment or whether it's having interests, it's having something that you want to do. And
Yeah.
a lot of them like to go to church. The Heights Church is still a really big church there. And the people there are great. I mean,
Hobbies, yeah, classes too. That's another thing we really encourage people if they're dropped out in the middle of school to get back to school. So we have a lot of people taking online classes to try to get them headed back to whatever.
I think they want their computers, but I'm just going to leave it at that.
But
So, yeah.
that's okay. It's as long as they're doing something that's productive, I'm happy with that. I think it's they need to have goals. And I honestly, that's what I really encourage with patients is you got to have some goals. You can't just want to sit around and, do nothing all day. You got to have some goals in your life. And that, because it makes people feel better,
Yeah.
Yeah.
Well, it does. And it just, because we're social beings. And yes, school's really important. We've had people that we have helped get their GEDs. People have gone back to school. The cool thing about up there, and I think it's even here in Maricopa, is that the community college system is very good. And so we have Yavapai Community College, right? Yeah, I just blanked for a second.
Yavapai College.
Yeah, whatever. Yeah, okay.
Yeah.
We also have Prescott College up there if they
Yeah.
want to go to school, and that's an interesting school. It's more experiential. They have a lot of interesting majors there, but so there's a lot there, and we do encourage that. We also encourage people to think about, we try to help them kind of like step by step, baby steps, and we expect them to have difficulties and stumbles, and that's why we want them to do it while they're with us, so that we can help them through that, and they don't just quit and and say I can't do it or whatever, and we help them get back up again.
Do you have issues with the utilization managers of all the insurance and
God.
eventually you will have Medicaid of wanting to step
say,
them down
Yeah.
10 days after they come in? Yeah.
Yeah.
Okay, yeah, that's the bane of my existence. So Dr. Vaughan is super helpful because she does the best peer-to-peers ever, and our whole team actually is really good, I think, at getting the most amount of days that we can. I mean, we do have a specialized, a kind of a niche population. We are not just a traditional mental health or just traditional addiction. But yeah, it used to be much easier. It's getting harder and harder. If we can get 28 days for like a residential level, that's what we'd be looking at. We can get I don't know, maybe, well, 30 for sure, maybe 45 or 60 for like PHP. We've been able to get longer because we have such a high acuity, and it takes a while to titrate. I mean, Dr. Vaughan, how long does it take a lot of times for us to see people where they can even start participating? In 60 days, wouldn't you think?
I would say 60 to 90 days to get, their meds titrated upward. Yeah. it's probably-
Yeah, and yet they still expect us to treat them, and they're all better in 90 days.
Ready
And
to
that's
go,
just
yeah.
yeah. So then you're talking about IOP, and interestingly, even with the private insurance, there's not that much difference, and sometimes they pay more for IOP than they do for PHP. I think it's just somebody messing in a room with an algorithm is what I think is happening, and seeing what they can do. But again, you're talking about, it's not a lot. And then what we've been seeing, if I could do a whole day on insurance, but what we are seeing is that payments are being made, and then they're requesting refunds, actually. Yes, we definitely take clients on COT. In fact, I like it when they're on COT, only because it gives you a little leverage sometimes. And I don't mean that in a mean way. I just mean that, there's some leverage. We also refer people to one of your founding people, because guardianship is a really great tool to be able to help, and especially even with and I'll get back to what I was talking about before, but court ordered treatment, and it allows us to be able to keep the patient until we kind of think that they're ready to go. Wouldn't you say, Terry, to a certain
Yeah.
extent?
And Rachel was asking how that works. So normally what happens when they're on COT is that there's usually a treatment agency, and honestly, they're always happy to have us take it over. Usually,
Yeah.
and frequently, it's funny. The last one was a nurse who's a nurse practitioner down in Phoenix, and I had supervised her before, and she's like, "Oh, Dr. Vaughan, please take over this patient." And then they just want to know when they're finished with us, and we let them. We let them kind of take back over when they leave us, but it's normally the Rebus are happy to have us take over the COT because it saves them time and energy and money. So, yeah.
Well, they
Okay.
need, yeah.
Now,
Yeah.
there's another request. Please elaborate on your sober living homes where some clients live while getting treatment as described on your website.
Okay, so we are talking about 4 or 5 bedroom homes in the nicest neighborhoods in Prescott, and they're someplace you'd want to live, and they we may in the beginning we want them to share a room, because there's a lot of reasons why, but one of the biggest reasons why is accountability, and they're not isolating. And then they can graduate, and they can earn, maybe having their own room as they're with us for a while longer, and some more as they're earning more independence. And it's not about earning. I mean, it is kind of about earning. It's about it's not that we are trying to restrict them. We're just trying to help them slowly regain their footing. I guess I would kind of put it that way. And so the homes there's 24/7 staff. We have someone on swing staff to help during the week. We do all the transportation. The homes are very close to the center of the facility. The one that's going to be the residential, or the residential, I mean, that's all, everyone's just all there. That they don't, the services are provided, they live there, they would live there and everything. But these homes, we require them. I mean, they also have, it's nice, they have their daily chores that they do, or their weekly chores. And it is paid, it's actually not covered by insurance. The sober living it's a separate thing. Insurance does not cover it. And that's, And we also, though, we've always kept the cost very low. We subsidize, we give them food allowances and we help them go shopping. We also have had a nutritionist on staff who will make sure, work with them individually on meal plans and things like that, and have helped them shop at the grocery store before. And then the food usually ends up, sometimes it just ends up in the refrigerator, but a lot of times they'll give them recipes, just simple things, but healthy things. And they like doing that. In the past, we've done Sunday night dinners, which is a nice community thing to do. And so if there's a more specific question about the homes, I'm happy to answer.
Okay. Any other questions for Dr. Vaughan or Amy Fackrell?
You've got
Well-
Dr. Vaughan here. I would ask her. This is a treat, yeah. Anyone can get a hold of me at any time.
No, but it was a
Dr.
pleasure.
Vaughan, so we have you, so I'm gonna, how do you have any programs maybe in the Valley that you recommend discharging to, or other psychiatrists that you like, that you've handed off?
Rachel, I would probably call you. and ask
Okay,
you
that's
about
what I
that.
thought you'd say.
Yeah, so that's where we would be, because it's interesting. I think it's difficult to find good programs you guys would be my resource to find where to send people to when they're done, up here. So, yeah.
Well, yeah, and if you're talking about just the Valley, yes, we use what the best resources that we can, and people who are in the front line and really know, because someplace we have to keep up with, someplace might have been good, but there might be a change in, ownership or leadership or whatever, and it could be a problem, and that's happened before too.
It is.
It is hard. A lot of them will end up going home to their homes, and then we'll get a call, and then we'll call you. No, then we'll find out. But what we have been trying to do, and it's really important, is try to create a nationwide network. And so we have a lot of, we try really hard in different areas of the country, and we seem to get, it seems to come in waves. We get a lot of people from the Pacific Northwest. So we're always constantly putting together and trying to keep updated with the best and most recent aftercare.
Yeah, we need referrals everywhere. Yeah.
Yeah,
And
yeah.
usually when people are Arizona, if they want to, I'm following up with them, and I see, have lots of families that I work with, and, I'll follow up with them after they leave. If they're out of state, we have people like
That
several
fly in.
people-
They
Yeah,
fly in to see you.
that fly in, they come back, every 6 months or 3 months, depending on the situation, just because they have trouble in other states finding good providers. So it is interesting. I just had a family from Utah. They want to pay for me to get a medical license in Utah. And I was like, well, I don't know about that, but
Well, wait. Don't discount that. We can talk about that later.
Yeah.
Okay.
So
And
Janine?
I just, for the
Janine?
record, real quick, I have
Yeah.
referred people to you to do a consultation
that a lot.
that
yeah.
helps supplement with what their psychiatrist has,
Mm-hmm.
has them doing. So just throwing that out there.
Yeah, I've done that a
And
fair
thank you
amount.
for doing that.
You're welcome. You're welcome. And, I talk to lots of desperate parents, and I've always felt, and again, I'm just, from my own point of view, I have my own, adult children. And I just think I really feel for families when they're having to deal with these situations, because it must be just really difficult, because I think most of the time they get into the hospital won't even talk to you because of HIPAA. And then then the person who's ill is saying they don't need treatment. And then it ends up going round and round in a really terrible cycle.
Yeah.
So we do our best to kind of communicate. So, yeah.
I think we do a pretty good job.
Yeah.
I think we do. Yeah. I think you do.
So Janine, you've been
I think
patiently
it's
waiting.
It's Jean.
Is
Oh,
it
okay.
Jean? Yeah, it's Jean.
Could you
Okay.
just explain how you do the court ordered treatment a little more? Someone's ordered on court ordered treatment for a year, up to a year. They voluntarily come to you. How does the whole process work? How long are they with you? is it private pay? Is it insurance?
Amy could probably talk a little bit more to the legal part of it, because sometimes we've had it where they are transferred up here. Like we had a patient where they actually transferred the court order up to Yavapai, but we also have had it where the order, like they'll just say it's fine to get treatment from Maricopa up to Yavapai County, and that we're the agency that, or, you know, obviously we're not an agency, but we're the provider that's providing services. And some of those have been under their private insurance plans, which is interesting. I don't, you know, because they still need treatment. And we've been able to do our PHP under the insurance plans, but
So
There's also something that just happened for the first time and it's very exciting. So there was a client that was in Florida in jail and they have their Baker Act and all of that. They hired this defense attorney who's like, he's very high powered and he's like fighting all the death penalty cases in Florida. And yet he never knew about anything about mental health, even though most of his clientele has mental health issues going on. So I worked with him and we worked with them and he was able to go to a judge in Florida for the first time. It was the first case and get the COT order that allowed the patient to come to us in Arizona. So we also are able to do that from out of state. And that's incredible. Because they didn't have a facility, or quite frankly, they probably wanted the kid out. I think in this particular case, they wanted him just to be out of Florida. And that's okay too. But because sometimes it is good to come to another place and a little, you know, the different people, places and things that they talk about. And then to talk about court ordered treatment. So yeah, they come to us and we are under the requirements of whatever the order is. We will have to provide you know, reports, which is fine. I mean, we have no problem doing that. And yes, it is either private insurance. Actually, it would be private insurance or a cash pay situation. We do cash pay situations, and then we are provide super bills, or we help the families in any way with trying to get reimbursed. And I think we're trying to help Lee and Lori here with some stuff, and it's been really fun working with them and all of that. But we need all the help from the families we can get with that.
Thank you. Any last questions? I don't want to keep you captive. I mean, we go on for another 50 minutes, but you know, I know that you didn't commit to 2 hours. So anytime that you need to.
I'm sorry to interrupt, Lori. I thought Jean maybe had another question. Did you have more, Jean? Because I'm fine staying a little longer.
Well, I was just, you know, I was just curious. So someone
Okay.
say Yavapai County, they're ordered on court ordered treatment, and so they voluntarily decide to go into your residential program, and they're either private pay, cash, insurance, but they can stay there for the whole year of their treatment if they desire.
It's not really a year. And I mean, yes, but it's actually, if you look at and I'm going to defer to Josh a little bit on, because I'm trying to, and of course, Judge McDougall, but I believe that it's 180 days. It's 360, it's a year, but it's 180 days inpatient treatment. I mean, there are certain things back and forth, but yes.
So would that be considered inpatient? Because that's not, I don't know what the real definition of inpatient would be if it's hospitals.
Yeah, that would be locked. That'd be a locked facility.
So if you're voluntarily there, you could stay then the full year.
Oh, absolutely. Yeah. And they don't really run away. In fact, we have a hard time sometimes getting them to graduate. And I'm actually kind of proud of that. I mean, I'm kidding on the square with that, but
typically what happens, Jean, is that I do work with the providers in the Yavapai County and at Pilara when we're having issues with patients. So that is normally what happens. So.
Or they've got, or I think, they can sometimes go to jail. or not jail, but they would go to, back to,
The connections, they can go to.
connections,
But
yeah.
normally I'll coordinate care with, you know, the folks over at Pilara, and, you know, it used to be Courtney, and now it's a couple of that, Nathan is over there and a couple of other providers. I work with them all the time in Yavapai County, so.
Thank
We
you.
work really well with all of them over there.
Yeah.
Thank
I
you.
recall that basically Dr. Vaughan gives your notes to the behavioral health provider at the clinic or program where the COT was assigned, and then
Yeah.
they submit the monthly reports based on their communication with you. Is that accurate?
Yes,
Yeah.
and normally they can just say that we're, you know, carrying out with it. And then we are obviously have a duty to say, okay, if this person is non-compliant, or let's say they decide to run away or whatever, then we'll kind of report back to the agency that's managing it and say, you know, let them know we can't, you
And
know.
they have to do the amendment, if I understand correctly.
Yes, yeah, they do. Yeah.
Mhm.
Typically, they seem happy to do that. At least that's what I've noticed.
Well, thank you very much. That explains it a little more.
Yeah. Okay, thank you, Jean.
Dr. Vaughan, hi, it's Holly Giesel. Hi, Amy.
Hi, Holly.
Holly, I'm so sorry about the university club. I'm so bummed.
I know, I am too. I am too. So I want to go back to your first slide. I thank you very much for that slide deck. It was excellent, and I love the way you started. You mentioned that Arizona meets about, I think, 4% of its mental health needs.
It's low.
If we focused on only SMI, not all mental health needs,
Yeah.
what 3 things could Arizona do to meet 90% of our mental health needs?
Well, in my opinion, I think the big, you know, weaknesses that I see are having enough trained providers that are experienced with doing treatment for chronically mentally ill, seriously mentally ill. Because sadly, you know, I see there's some of us around, but, you know, there's just not the pool of knowledge. And a lot of people are, you know, maybe inexperienced with dealing with these kind of illnesses. And, you know, I look at what they've done and I'm like, oh my goodness. The other thing, frankly, I'm just going to say it, and I would imagine families of people with these kinds of issues would have seen it as well. I see providers that are really kind of very, I don't know, they're not willing to kind of push, you know, like getting treatment, and they just are very much in favor of like patient, I hate to say it because it sounds so negative, but they're in favor of patient rights, but that would, you know, they just don't listen to the families, and I think that's a major issue. So it ends up with people having recidivism and suffering in the long run terribly. And I don't know, I had a patient I took to court for a court order, and I thought it was a slam dunk case. I was like thinking, oh, how are they? Because he had been psychotic and his eye he thought was evil. So he took it out with a toothbrush, sadly. And I know, it's sad, sad, sad. But we went to court, and the lawyer spent an hour arguing with me and the family about how wouldn't it be better if he lived a short but happy life, staying off meds and doing what he wanted to do. And I was just like appalled. And I was just, you know, the family was in tears, you know, he had like grandparents, aunts, uncles there. But isn't it awful? And I, you know, I just sometimes I think about that case, and I think that there are people, and there are people who are psychiatrists and NPs, you know, mental health providers who have that thought, and then it ends up, you know, families aren't getting what they need and patients aren't getting what they need. And I you know, my response was, I think once he's well, he would be really happy that he has his eye. So,
Oh
yeah.
my God.
How did the court rule on that case?
They ruled in favor of what I was asking for, which was the court order, and he ended up going down to Ash because he was so very sick. I mean, he was going to the ER and trying to cut his hand off too. I mean, this is like one of the sickest people I've ever seen, and I was like, what? I mean, I thought I was going to be in there for 2 minutes and it was going to be a slam dunk, but luckily the judge was really, he was I don't know, he was a newer judge, and, but in the end, the family, I think that was what persuaded the judge when they saw them in tears and, listened to the case. But anyway, I think that's the case. And then I really think, obviously more funding and a more residential care, because what happens is we do frequently get people kind of whipped into shape when they get admitted, and then there's no follow-up. And with our people with these kind of chronic mental illnesses, they frequently they don't continue to be compliant. And I know Amy and Joe and I see that with our program. We really have to set up a firm discharge plan, because it doesn't, I mean, it's so sad because, we'll do all this work and get people into shape, but if we don't have a good discharge plan together, where somebody is managing the meds and they have good housing and they have, they're sober, it doesn't matter. I can get that, it's just all gone, and it's such a waste of time and, effort and, money that we've gone through that. So I think those are the big things that
Did
I've got my
some-
top, oh, I'm sorry, go ahead.
yeah, go ahead.
Did,
Yeah.
Thank you.
did some organization pay that lawyer to come in and argue that? Who was the
He was
lawyer
a public
representing?
defender,
How
wasn't
was
he?
getting
He was
paid?
the county lawyer.
He's the public defender,
He
yeah,
was the public defender.
yeah.
Actually, that I'll just say, this is Dick that's talking right now. So the ironic thing is he ended up getting a really terrible in the paper DUI that was like major. And I ended up treating him in the long run. And like, as we went down the road, and this has been a while, so I don't think I'm giving anything up on that one. But I was like, oh, this is such, it's like such justice in the end. So
I want to say one thing, and this is, I have a legal background, and yeah, everybody is entitled, and yes, they have advocates, and they should, okay? But
Yeah,
you're talking, they
people
should.
can take advantage of people too, and that's why
Well,
you have to get people that are ethical and working in this field too. Yeah.
so that's exactly what I was going to say. I think you've got a lot of people who bring their own bias into something, and it's dangerous sometimes. So one of the things the most key is education. The second thing is, let us treat the patient for as long as we need to, the way we can get it done. And then let's come up with some better long-term housing communities, because it's a long-term problem. My dream is to have a campus where you have, someplace that's a stabilization. Actually, Patty Henderson used to have the best place in the world. Hi, Patty, how are you? It's nice to see you. And I know you have your hand up, but where it's a community there. And I even think ASU had started to put something like that together. I think Molly McGinn's treehouse program, they had a place at ASU, which is great. But
Yeah.
I think it's important that we have a place where people can live. They can have a place if they need a little extra help or they need some stabilization, because I think everybody does at some point. I mean, the doctors can speak to this, but I don't know if any of our clients who it's just once they're on and on a good level, that just stays that way. And then the other thing is having some independent living, but with structure and with somebody living, kind of living there on premises, which I believe that there's going to be a really exciting one that COPA is opening up soon. That's going to be like that. And giving them a place where they can go. Patty Henderson, I think, how many hours did we sit planning this one day where they could have a place they could go make music, or they could go, learn and to do something, but feel safe. And those are the top three. And those are that's not a tall, I mean, that's a very tall order. So that's what I think.
Thank you both. Those are great ideas. I appreciate your having your thoughts on that, given your backgrounds and your expertise. Thank you.
Thank
So
you.
you're going to get it done, Holly? Can you do it for us?
Let's say November 1.
Okay, cool.
Okay, perfect.
That works.
We'll
So
give
Patty-
you till
Of
December.
2030, you didn't give us a year.
Oh, no, 2026. I have a big Halloween planned with my granddaughter, or I do it October, 31st.
Aren't you selfish? All right, Patty, I'm sorry, Lori and Patty. Yeah.
I'll let Patty go first.
Okay.
You have to unmute.
You're on mute, Patty. We can't hear you.
You're still on mute.
Still on mute. Let's see.
Take the, yeah, it's the little
It's
little mic button.
little microphone. There you go. Oh, now she's got her.
That's okay, as long as we can hear her.
We still can't hear you, Patty.
No lip readers?
Lori,
Now, but now her picture's gone, so I can't even see her picture. So
well,
we can-
Lori, do you have a question
Okay.
you want to interject
I
while
do.
she's figuring that out? Yeah.
I was just going to ask Dr. Vaughan because I know, I'm not sure if you brought up this during the clozapine discussion, but do you start someone on clozapine if you know that they don't have stability to go back to? Because as in the discussion with, I'm trying to remember who was discussing it. If you have a couple starts and failures,
Yeah.
you know, the amount to get you back to stability goes up. And so will you start someone if they don't have sound
So-
family and sound structure to go back to?
Not normally, unless I know that I'm going to be having them in the program for a long enough time to get them stabilized with it. And I will say that sometimes what I'll end up doing with folks like that is maybe I'll do the clozapine with, you know, in addition to an injection, a long-acting injection. So they've kind of got that underneath it. And I know Joe and I go through that a lot because we're like, oh, maybe they're not going to stay on it. So we'll do that LAI underneath it so that, you know, we've got both there for when and if they decide to go off their meds. And usually then they don't get quite so, you know, decompensated if they go off. And, you know, we do our best to try to make sure they've got a secure environment when they leave. So.
Dr. Vaughn, there's one other thing I think is important, and that there are a lot of families, there's a lot of stigma still, and they don't want their child to have a mental health. We don't really label people, but sometimes there's a diagnosis, right? And so I know that you have at times the client and the families have wanted you to titrate the client off. And I'm not necessarily saying clozapine, although maybe that's happened, but I know recently they want you to titrate them off while they're in a safe environment to see what happens.
Yeah, yep. I've had that, and sometimes, you know, we've had a few parents that are like really overboard on different kinds of supplements. I mean, like really overboard, like, you know, 30, 40 supplements. And so really overboard. Like, I'm not against supplements, but like sometimes it's like, wow, they're going to get sick to their stomach because there's so many. And that is sometimes those families, like, they're not thinking the same as I am. And I'm like, well, I think we're going to need some stronger meds than omega-3s. Yeah.
So Patty, you're unmuted.
Yay!
Finally, it's my iPhone. I can't seem to find the buttons down there. Anyway, thank you for taking my question. Dr. Vaughn, Amy, you know, as you're speaking, what's coming up for me is that as a guardian and as a grandparent who's very involved with my grandson, I don't always know what to do to help motivate him to start engaging in life. And is there some parent education author, speaker that is particularly knowledgeable about this? Because I think that some of us fortunately have a lot of influence on our loved one, but we're you know, we're not trained and don't really know how to get that motivation going. You know, I been talking to Amy about my grandson perhaps coming up there, but I always wonder about the after effects, you know, and how. I mean, I know that if he stays in the same environment, makes friends and stuff, that's you know, that takes care of a lot of that. If those friends are in recovery and, you know, and pretty healthy, but what about parent education? You know, when you are working with the clinics, you know, and the veils. I mean, you're just so busy doing all that stuff. You know, missed appointments and yes. Okay, I'll just conclude there.
No, it's great.
I think there's probably, you know, groups like this, and we have a lot of, you know, support groups out there for families of people with psychiatric illnesses. And that would probably be the first place to point. I'll see if I can't find a good resource for you, Patty. Just
Thank
like
you.
specifically for that. I promise, and I'll get a hold of you through Amy because I think she's got your contact. If anybody else has any brilliant ideas on that, certainly maybe speak up.
Are you talking about motivating, getting the kids motivated?
Right.
I don't think
And-
that's actually just a problem for people with the SMI population. I think that's kind of an issue.
A parent problem nationwide. But
Right.
I will say this, and I'm just going to put this out there, and I think Joe will agree with me. So we've had many a patient in our program who I've thought was never going to be doing anything. Like I thought they would never go to school. They would never get a job. They, really would just be taking meds, and we would, just be, treating them, and that would be really their whole life. But I have to say that the families that are the most involved with these young people, and that drive us a little bit crazy because they're always calling us and they're always concerned and they're asking questions, and they're high maintenance families. Rachel, that's you. But those families, after people leave, they do so well. And honestly, like they achieve things that I would never have imagined. And the magic happens really after they leave a lot of times with some of these people. And Joe and I could talk. There was one young man that we treated for a long time who is out of state. But when he left, he was like, he was doing okay and he was no longer psychotic. But once they got him home, they were like slave drivers. They had motivational things set up, with him, like different ways to motivate him. And they had him, he's like exercising and he's working in a program and he's doing therapy and all those things. And so I've become quite the believer in like parental, like, I don't know, methods of getting people moving, because it is a hard thing, especially with the schizophrenia diagnosis, because sometimes that lack of motivation is really a part of the illness. But I always kind of just accepted that, and I don't as much anymore, because I see that like if you really do work at it, it's possible to get, if you work with them at where they're at and what they're interested in, that to get them motivated and moving. It's kind of been a really interesting thing for me as a psychiatrist to see some of these young people do better than I thought they would. But that's not everybody, because some people don't get well, with treatment. But it is possible. So we have
Thank you.
Pat,
Yep.
okay. I think
Appreciate
Chuck, if Patty's done, Chuck's
Yes.
next, and then Janina.
Yeah.
Oh, so I wanted to ask you, as I'm sure you're aware, of course, that clozapine is supposed to be used for treatment-resistant schizophrenia.
Yeah.
But for those of the audience here who don't know what that means that the patient has failed on 2 previous courses of antipsychotic drugs.
Yeah.
However, lately I've seen some literature saying that it's the drug of choice in psychosis that is caused by cannabis. I've seen some papers on it.
Yeah.
I'm probably aware of that. But in your practice, do you adhere strictly to that format, or do you occasionally look at people and say, I'm putting this person on clozapine right off the bat?
Terry, do you ever like stick to any strict format of anybody?
Got to be able to think out of the box to do what I do. But I would say, the problem still with clozapine is, even though they've eliminated the REM system, you still have to do the blood testing. So it's going to be, you still have to have somebody that's able to do testing to check for the agranulocytosis. And I know the myogenes, we're looking towards that to help us be better at predicting that. But that is going to keep me from prescribing it to everyone right off the bat. Just, I think I can usually manage side effects, like fatigue and weight gain and whatnot. I don't have much trouble with that usually. But I really, the whole thing with the blood testing and, a patient that doesn't have the support, it can be really hard to do that. And, kind of a lot of people don't want to, whatnot. But I don't always stick to the, like, you have to have failed too. We've had a few, and sometimes I can just see them when they walk in the door. I'm like, okay, you're going to need clozapine. Like, I just know it. It's just like, this is not good. But usually it's not going to be number one. It's going to be two, just because you're going to do something in a crisis in the beginning that's easier.
But Terry, weren't you, when you were in medical school and coming and training and everything, they used clozapine? I don't think they were teaching it, and there's that, what you have, that innate sense, you can't buy that or teach that sometimes, but I think that's also a problem.
Well, unfortunately, psychiatry is at least I think it's pattern recognition is really what it is. But I think Chuck probably saw the same thing in some of what he did in medicine. It's pattern recognition. We're like big AI machines. So but the bottom line, yes, when I was in my training, they taught using clozapine. And I think especially if you're a psychiatrist and you learned inpatient, I worked at the state hospital in Indianapolis, and so we saw lots of people on clozapine. So that was something that was like, easy peasy.
Oh, thanks.
Yeah.
Janina?
Hi, Dr. Vaughan. Finally, it's very nice to finally meet you. I've heard about you from Rachel all the time. So, I'm a huge fan of clozapine. I'm a Psych NP at COPA. To kind of piggyback on what Dr. Goldstein said, we don't have to wait 10 years for somebody to utilize clozapine. But what I find amazing about your program, and actually, coincidentally, I'm working on a new treatment model because the way things operate in the system currently, there's just not they just don't work. So, the medication portion is very important. So obviously, the expertise of a provider that knows what they're doing with clozapine is very important. And, I'm clozapine all the way. But the other part is the rehabilitation, quote unquote, where, cognitive enhancement therapy, CBT for psychosis, milieu therapy, community, because what Amy was probably referring to, like when they when people share a room, they have to learn how to interact. And a lot of times, patients with severe psychosis, they're almost like they've been in a coma for years, and they all of a sudden they wake up and they don't know what to do. So learning social skills, learning, healthy interactions and all that.
Yeah, ADLs, learning how to shower,
yes.
how to
even
cooking,
cooking,
those kinds of things.
Yeah, even cooking. I think that's amazing. And well, we're not going to steal your model, but I definitely would like to, with the support of the advocacy that we have in Arizona, to build something similar, because my latest saying is, if we keep shuffling the same deck of cards, we're going to get the same results. So we need to put a wild card in there. And I would definitely like to visit and tour the program and talk to you some more, because we need something like this in the Valley, like air.
Yeah. Good. Well, and again, I think Amy, Amy, I'll let you talk, but I'm sure we wouldn't. It's not, do we have a patent on anything? Not really.
No, I'm just kidding. No, in fact, we're happy to share, because if I'm glad that I appreciate what you're saying, and it's a compliment. Please take what you can. This is about a community. This isn't about trade secrets. This is about take the secret out of the equation, and we all have to come together and be
absolutely.
Takes a village. Yeah.
Yes, absolutely. And I can definitely share my.
You can't have Dr. Vaughan though. There's some certain things. Joe.
Well, listen, there's only one Dr. Vaughan, and there's only one Janina, and I have a lot of things to learn from Dr. Vaughan, and I'm more than happy to do that. So it's an honor, Dr. Vaughan.
Oh, thank you.
Yeah.
Nice to meet you. And yeah, if you ever, want to.
Welcome to come up anytime you want.
Yeah.
I can tell you as a parent of someone that finally found a good psychiatrist and he's doing really well. My
Yay.
nightmare is if she ever retires or gets hurt or
gosh.
leaves,
Right.
we will follow her. I mean,
Yeah.
she's great.
That's the same thing I get. Who are you working with down there, Lori? Can you share, or is that
Yeah.
a secret? Yeah.
Dr. Beatrice Mateus.
And I've
She's
heard-
great.
Yes, I've heard good things about her, so
Yeah.
I'm glad. Yeah.
She's the kind of psychiatrist years ago when he was still having fluctuations, she would say, well, why didn't you text me? I said, you were on vacation. I'm not going to text you. And she said, don't ever do that again. You text me.
Aw.
You call me,
Okay.
I mean, so she is amazing.
And I'm called 24/7 for Amy, but
Yeah, if you guys want to get through, you're gonna have to go through me. I am the gatekeeper and I'm
It
pretty
is
strict about
but
it.
it is true. I was on I was flying to Ireland and I got, jeez,
That was your mistake for going on vacation. What can I
I
say?
my bad idea. Yeah.
Any last questions? I mean, I really appreciate it. I'd love to go up and tour the program sometime
Yeah.
because I hadn't known anyone except Rachel that had experience, and I knew there were a lot of other
Yeah.
programs that aren't as good in Prescott. Let's just say that.
Well, I'll tell you what, I know somebody who might have an in to get you an invitation. I'm just saying. Okay, so we'll talk later, okay?
Okay.
And actually,
Thank you, guys.
everybody here is involved in, and I just want to say thank you for letting us talk and great questions. And Dr. Vaughan, thank you for doing this with me. I mean, I can tell you, whatever, and